Thank you very much for allowing me the honor of bringing a welcome from the AMA to Mississippi. I'm hoping that they will be able to bring my slides up. Great. This is an amazing conference, and I have to give a lot of credit to the leadership, to Governor Bryant and everyone in this room for recognizing the importance of health care as an economic force. And so I want to focus my remarks along those lines. I wanted to point out nationally what the effect of health care, and in particular physicians, and in this slide private practice physicians, bring to the entire country. $12.6 million, you can read the numbers yourself, for the amount of money that we help to provide in terms of a contribution to the nation's economy. And I think that's only part of the story, because it's impossible to calculate, as you've heard many times here before, that having a healthy workforce who shows up to work every day and gets the job done contributes enormously to the economy. That having an infrastructure of health care allows other businesses to say, I too can come to that community because I know my employees will be taken care of. So $2.3 trillion for physicians are the contribution. And that, we love this slide because that's even more than the lawyers. It's they contribute $724 billion, whereas we're up in the trillions. And even higher education, as valuable as that is not the same economic impact as physicians. So as we look at jobs, an economy needs jobs, and it needs good paying jobs. And physicians providing nationwide 12 million jobs. And the jobs that are provided in healthcare, as many people in this room know, are not only financially rewarding, we not only provide good benefits, but it is emotionally and intellectually rewarding work. We give people the opportunity when they work in healthcare to go home at the end of the day with that feeling of, I have helped someone, I have done something worth doing today. And the emotional ability to do that is enormous. But for economic activity, every physician in the country supports numerous jobs. The average is about 17 jobs per physician. So the repercussions of that are enormous. The $2.3 trillion is divided up into direct and indirect, and I'll talk about that in a minute. But the average economic output per physician is over $3 million. So investment in physicians is incredibly important. The wages and benefits, and I hesitate to point out, in a room full of lawmakers, that we pay a lot of taxes too. $92 billion are paid nationally by physician practices. All of this data comes from the AMA's Economic Impact Report, which we put out every couple years. This is from the 2018 report, so it includes data up through 2017. And what we do is we look at the direct costs and the direct impact we have in terms of wages and benefits. But then you realize that every person that we employ buys groceries at the local grocery store, fills their car up with gas at the local gas station, visits the local other healthcare providers, gets their taxes done by the local accountants. The circulation of that money is a significant multiplier. So as we look at that impact, we try to estimate that, recognizing that we can't estimate what fewer sick days mean, what having healthy workforce means, and the ability of companies to look at a community and say, I can put my business in that community. So we have this economic impact study, and I show this blank map because you can put your state in the drop down and pull up information state by state. So this is on the AMA website. And so I pulled up Mississippi's. You have over 4,500 physicians in this state, which means that the economic output of the physicians of the state of Mississippi is over $8 billion. $1.8 million per physician, and that's a lot of wages and it's a lot of jobs. It's over 50,000 jobs here in Mississippi by physicians. People forget that we are also small businesses, and that's an important consideration for all of us. But it's a lot of tax revenue as well on those wages. The $3.8 billion in wages generates $313 million of local and state tax revenue. That adds value to the community and helps build projects like we just heard about with the Tradition Medical City, which I think is a fabulous idea. So when we try to figure out how do we place physicians, we know that there's a maldistribution. We all know that rural communities need a physician to be able to get health care locally, because health care is local, and given the fact that in this country we spend $3.3 trillion on health care, and 90% of that is in the management of chronic diseases, you've heard many times today, diabetes, heart disease, hypertension, etc., that managing chronic disease has to be done locally. It is an ongoing continuity of care requiring process that allows the patient and the physician to be able to work together to keep that person healthy. And keeping them out of the hospital and keeping them healthy adds enormously to how well people can be part of the workforce. So I pulled up this website as well, and it's a useful one to have because you can look at the workforce mapper. Now what this does is it looks at when you train a resident, where do they go? This is key. Now the pipeline for creating a physician is quite long. After 4 years of medical school, you have an MD degree, but you don't have a job. You often have over $200,000 worth of debt, but you don't have a job, and you can't get a job unless you have had a residency. So graduate medical education has got to be your governor's next step in terms of once you get people graduated from medical school, they need to have a residency, because we know that where people do their residency is where they are likely to stay. And Mississippi does pretty well in terms of having the residents, the red part is the residents who graduate from your local programs, where do they practice? And I think not nearly enough of them go to New Mexico, where I'm from. So if you have extras, you know, you can let me know, we'll bring them there, because you rank 50th in lack of physicians, we rank 49th. So if you're not watching, we'll come and try to steal your people. So, but this is an important map. This means that your universities are doing a good job, and with your new medical school, you need to have those graduate education programs so that they can also keep the graduates of that school here in Mississippi, out in the rural areas, providing health care to people where they need it, which is near their home. Now, with health care today, the AMA is focused on many of the big problems that confront us. Access to care is not just the lack of the workforce. We are working with team-based care. We're trying very hard to make sure that all of those teams have a physician leader so that we can work with everyone else in the team to make sure that the care that is given is best quality we can give. But we need to make sure that patients can also afford it. We know that there's a tremendous high cost of health care. I'm an oncologist, and drugs are part of the problem. They are enormously expensive, but they can create some remarkable outcomes. But we also know that 2/3 of bankruptcies are triggered by a health care event. and that 2/3 of those people have insurance. So we have to continue to address the high cost of health care. About 14 to 15% of that cost is spent on regulatory burdens, prior authorization, what I call to physicians the mother may I of medicine. May I please give this patient the antibiotics they need for their pneumonia? Why do I have to ask permission for that? We look at the health sector consolidation, and this is very concerning. Health sector consolidation tends to be in bigger urban areas. It is not particularly interested in smaller rural communities where 40% of Americans live. And we've known for some time, as we've watched this consolidation of health plans and consolidation of hospitals, that what happens is that prices go up, choice goes down, and if you're lucky, quality stays the same. So we have been on record and testifying in front of Congress against the consolidation of the big 5 insurance companies into 3, and most recently opposing the CVS purchase of Aetna. We will continue to work on that. The opioid epidemic was eloquently addressed earlier in this meeting, and the AMA has had an opioid task force since 2014 looking at this issue. Originally, pain was the 5th vital sign. We were all penalized if we did not keep our patients 100% free of pain. Well, that was the wrong message. A, it's not possible, and B, it results in addiction. So now physicians are taking the lead and educating ourselves, cutting down our use and prescription of opioids significantly across the country, checking the prescription drug monitoring program so we can recognize doctor shopping. But 72,000 people died last year of opioid addiction, of overdoses, because when those pain medicines are not available through us, people are going out and getting them on the street. And there's some new chemicals on the street, like the congeners of fentanyl, that are incredibly lethal. So we have to do more on this. You heard what a devastation it is to the economic development. It is a disease. We need to stop stigmatizing it. It is not a moral failing or weak-willed. It is a chemical dependency that has to be addressed. We need to have more options available to us via insurance companies, that we can not prescribe opioids but be able to have better access to things like physical therapy. We need to have treatment programs and training programs, and I hope your new medical school will include a significant curriculum on how to manage addiction, because that will be key if we're going to reverse this burden. And the technology. Technology can be a wonderful thing. How many in the audience have a smartphone? Every doctor in the world has a smartphone. We all love technology. We just like technology that works. Unfortunately, our electronic medical records can't talk to each other. They can't share information. We spend 2 hours clicking on the computer for every hour we get to spend face-to-face with a physician. This is or with a patient. This is driving physicians crazy and leading to burnout and people wanting to leave the field. We don't want to create data. We want to treat patients. And that contributes to the fact that our healthcare in the U.S. is the most expensive on the planet, at $3.3 trillion, estimated to go to $5.5 trillion by 2030. If this continues, we will not have money for other episodes, for parks and roads and bridges that don't fall down and all the other necessities of life. When we look at this, we think if our outcomes were that much better, maybe it would be worth it. We rank 19th in overall health outcomes for the world. We rank 32nd in life expectancy, but we're paying almost double for that. That has to be addressed. It's unsustainable. And Medicare is feeling the pinch, because Medicare spending, and especially as we all age into becoming Medicare recipients, Medicare is going to have to struggle increasingly to be able to cover the increasing number of seniors, most of whom have 3 to 5 chronic diseases that require management. We're going to have to not only figure out how to deliver that care better, but we're going to have to figure out how to deliver it in a very smart way so that we use those resources very, very wisely. One of the things that comes to mind is this: if you look at this top green line, that is what hospitals have been paid since 2001. Every year they're granted what's called a market basket increase, looking at goods and services. The green line in the middle is the government's estimate of what it costs to deliver care. And that red line at the bottom is what physicians have been paid. When we look at this, what this means to me is that if I sold my practice to the local hospital tomorrow and saw the same patient tomorrow that I saw yesterday in the same office, did the same thing, it would cost Medicare twice as much, and it can cost commercial payers 3 to 5 times as much for the same care. We have to think about that, and we have to do some wise choices. If we want to cut costs for health care, the best way to do it is to keep people healthier so that they're not in the hospital. Manage the diabetics so that they're healthy before they end up in dialysis or having an amputation or an MI. We have to use our resources wisely. And as we look at patients, what's happening in a lot of the insurance industry is that they are pushing more of the costs onto patients in terms of high deductibles and big co-insurances for essential drugs and services. Well, the average American can put their hand on $500 when an emergency strikes. Yet we've delivered them a health plan that requires a $6,400 deductible. My patients come in with me to my office and they say, I've been waiting on this breast lump till I could get my insurance card. I've got an insurance card. And I say, but you have a $6,400 deductible. That's not fair. We have to address that. And so shifting the cost onto patients is not going to work very well because they simply cannot afford it. And if you're not sick, if you're not healthy, you can't go to work. You can't get your hours in to get your paycheck to be able to afford anything else. So we're really going to have to look at how we structure insurance so that people can get the care that they need. Because too many Americans in the richest country on the planet are not able to get the care that they need. If 40% of us cannot afford their deductible, then we need to restructure how deductibles work. If 1 of 3 of us cannot afford our premiums, then we need to look at how we can control the costs of those premiums, where we can make cuts that will help patients get care. My first choice is usually the administrative burden. Why are we spending 14, 15% of costs shuffling paper from place to place instead of delivering care to people? And we really need to be able to look at the bankruptcies and the devastation that we're causing families when they are unfortunately struck with a major illness. So what are we doing about it as the AMA? Well, we see a lot of dysfunction in the healthcare system, and we hear about this from doctors all across the country, from patients all across the country, from employers and from legislators who are saying, what is it that we can do to try to fix this? So we are spending a lot of time looking at those barriers to allowing the doctor to efficiently be able to give care to the patients. And part of that is clearly we'd like to have an EMR that actually assists me in taking care of patients. We're entering this incredible world of personalized medicine where you can look at the genes of a cancer and pick the best treatment, but nobody can remember that. Why does my EMR not give me that information? Remember to check for these 10 mutations in this type of cancer. We need data support for that. We need technology to be revised and to become something that assists us instead of having an hour with the patient and 2 hours with the computer. And you've all seen that happen. We are also working on the chronic disease burden. We have a program I'll talk about in a minute for looking at prediabetes and looking at hypertension, because those two are both huge impacts on the amount of money that we spend delivering health care in this country. But for this group, I also want to talk about what we're doing with education. That medical education has to be a lifelong learning process. We spend 4 years in medical school, and that's not enough. And then we do a residency, and that's not enough. If you want to do a subspecialty, you do a fellowship. But then when your fellowship is finished and you're out in practice or you're in an academic setting, the rate of change in healthcare is enormous. We need a way to keep up. So we've created the JAMA network and an educational learning platform so that digitally we can provide physicians from all across the country in all specialties with the information that they need, not only to keep up with their field, but to keep up with what's happening in the delivery system. So we're talking about diabetes. You've heard a lot about diabetes so far today. And there's 3 ways, really, that we're going to be able to decrease healthcare costs. One is to pay everybody less. But you know, my nurses, my pharmacists, my doctors want a raise every year. So do the secretaries and the entire team. That's not going to work too well, or people will leave the profession. We can carve people out of the system and say we're not going to give anybody from here over any health care. That would save money in the short term, but it doesn't work very well in the long term, and it puts physicians in an intolerable ethical bind. Or we can say we have this pot of resources. How do we spend it more wisely? And we've come to the conclusion at the AMA that the way to spend that money more wisely is to intervene early in diseases, before those expensive complications occur. Let's figure out who is pre-diabetic, and let's manage that so that they can make those lifestyle changes that will help them prevent full-blown diabetes and all the complications of that. And we know that there are a lot of people with hypertension who actually have a physician, but their hypertension is not well controlled. And so we're working to address that. As we do this, we recognize that this is not something that physicians are going to do by themselves. It takes a community. It takes people with innovation and vision to recognize where the future needs to be. We want to bring a healthier future. We want people to recognize that if we're going to try to prevent prediabetes from turning into diabetes, that patients need to have not only a healthy place to work, but they need to not live in a food desert. They need to be able to have access to fresh fruits and vegetables and to know, first of all, what they need to be eating, but to have the access to that. In the countries that spend more promoting good health and by addressing the social determinants of health, like food deserts, they can have a healthier population and spend less on health care. I think this is a goal. I want to commend your governor, Governor Bryant, for having the innovation and the vision to see that not only can physician practices become a very strong economic advantage for a state, but we are part of the infrastructure that can help the entire state have a better outcome and live a healthier, happier, and more prosperous life. Thank you very much.